Good morning, everyone, and welcome back to the Clinical Management webinar series of the WHO. This is the third of a clinical management webinar series that we've been holding. The first one was last April or earlier, and then the second one was June. This is the third one, and we are now in the third session out of 5 days. We are fortunate to have with us today a guest lecturer, Dr. Jyoti Somani from Singapore. I'll be introducing her later in a bit. And also still with us are Drs. Gary Kuniyoshi and Dr. Sophie Dennis. So before we go to that, a quick reminders, we now have 260, 260 participants and climbing. So we expect the Zoom room to be full. Usually if your app, what do you call this? If your app, yes, if your app is updated to version 5.03, it should allow you to get a reminder to shift to the YouTube link in case the Zoom room is full. So if that happens, but all the same, I will be putting the link to YouTube in the chat box so that if you have friends who can't get in later, just share the link to them. And I'll be doing the same from email while Dr. Somani is also presenting. And also a reminder, questions can always be typed in at any time. There is a Q&A box at the bottom of the screen. Just click on it, type in your question. If you see another question that interests you, just upvote it and it gets seen easier by the moderators. Before we go to the lecture itself, I'd like to invite Dr. Gary Kuniyoshi to give another few words from our sponsors, just a reminder from WHO on some of the clinical guidelines when it comes to COVID-19. Dr. Kuniyoshi, over to you.
Thank you, Albert. I'm going to go over some of the WHO guidelines in regards to COVID-19. This is from the Open WHO Clinical Care for Severe Acute Respiratory Infection course. This talks about the natural history of the disease. Most of this, the numbers here come from China CDC data. So these percentages may change, but the current definitions are for COVID-19 mild disease. This is symptoms without any evidence of pneumonia or hypoxia. How are these patients treated? Symptomatically, they get antipyretics, possible giving cautious fluids. Where are these patients treated depends on the local factors, what the transmission rate is, what the local resources are, what the local plan is. So these patients may go home with instructions. Moderate disease, this is pneumonia, but without any signs of severe pneumonia, and specifically does not require oxygen supplementation. And different tools can be used to differentiate the pneumonia severity, such as a curve 65 or the pneumonia severity index. These patients are also treated symptomatically, possible cautious fluids, and then treating co-infections if indicated. Where are these patients treated? Also dependent on the local factors, they may be treated at home. Severe disease is severe pneumonia, and this could be a respiratory rate greater than 30, respiratory distress, or requiring oxygen, which is a saturation less than 90%. And again, different tools can be used to differentiate pneumonia severity, such as the curve 65. Critically ill or critical disease can include complications such as sepsis, septic shock, or acute respiratory distress syndrome, ARDS. These patients are treated with oxygen, conservative fluids, empiric antibiotics, and may require ventilatory or hemodynamic support. So on co-infections, specifically on prescribing antimicrobial therapy for patients with COVID-19, in mild COVID-19, the WHO recommendation is against the use of antibiotic for therapy or prophylaxis. In moderate COVID-19, the recommendation is that antibiotics should not be prescribed unless there's a clinical suspicion of a bacterial infection. And special consideration should be given to older people, particularly those in long-term care facilities, and children under the age of 5. And these patients, you should probably consider providing empiric antibiotic treatment. In severe, and this includes critical patients, with COVID-19, the recommendation is to use empiric antimicrobials to treat all likely pathogens. And this should be based on your clinical judgment, patient host factors, and the local epidemiology. When you give the antibiotics, should be given as soon as possible, within 1 hour of initial assessment, if possible, ideally with blood cultures obtained first. And then after starting the antimicrobials, assess daily for de-escalation. Thank you.
Thank you, Dr. Gary. So that actually sets the tone for today's lecture discussion by Dr. Jyoti Somani on co-infection and the use of antimicrobials, where Dr. Kuneyoshi stopped the last bullet point on the use of antimicrobials. Well, that's where Dr. Somani comes in. And allow me to introduce Dr. Somani to our, let me check, 378 participants now and still going up. So Dr. Jyoti Somani graduated from medical school in 1991 and attended the University of Chicago Hospitals for her internal medicine residency and the first year of her infectious disease fellowship. She completed her last 2 years of her infectious disease fellowship at Emory University, and her research was in T-cell immunology and immune reconstitution after hematopoietic stem cell transplantation. Dr. Somani has had a peripatetic career with time spent in the U.S. Indian Health Service in academics as an assistant professor of infectious disease at Emory University, where she started the transplant infectious disease elective for ID fellows. She also spent time in Chennai, India, where she worked on an HIV and leadership training program for Indian doctors. She spent time in private practice back in Peachtree City, south of Atlanta, Georgia, and also lived in Jakarta, Indonesia, where she worked for the Australian Embassy Clinic and was also a consultant to Siloam Hospitals for quality improvement. She's been everywhere. In November 2014, Dr. Somani joined the General Medicine Department at Khoo Teck Puat Hospital, Singapore, where she practiced infectious diseases. In December 2019, she joined NUHS as a senior consultant for the Division of Infectious Diseases and as the clinical director of the Antibiotic Stewardship program. She is also now the director of NUH Epidemiology and one of the physician leads of the NUH Infection Control program. Dr. Somani is most passionate about the rational use of antibiotics and remains highly interested in infections related to transplant, especially hematology and HSCT. Please note that any discussions and opinions, although expert, are those of Dr. Somani, and do not necessarily reflect the official guidance of the World Health Organization. Over to you, Dr. Somani.
Okay, thank you very much. Mostly I followed my husband around who works for the CDC. That's why I've been to so many places and have had to try to adapt to where I am. So, and I think we all know adapting when we've been dealing with a whole brand new disease. So today I'm going to talk about bacterial and viral co-infections in COVID-19 because that is the topic. And I do appreciate WHO asking me to give this talk. I will first start with that and then show you some data, a recent paper on co-infections comparing COVID-19 to influenza H1N1 and then show you a little bit of cases on invasive Aspergillosis and severe COVID-19, something that we haven't seen really in Singapore, and I'm not sure you all will see in Asia, but it's good to know about it. And finally end with speaking about ASP, something near and dear to my heart, and the need for it in taking care of these patients. With a little bit of data from NUH and our ASP algorithm, which may give you a more practical approach to how to decide when to start antibiotics based on the WHO guidance. So we'll just summarize that and have time for questions and discussion. So this topic is very timely because two papers just came out either as in press, but not actually in the physical copies of the journals, but I could take advantage of that. And instead of showing you individual studies, I can show you this paper, which was a systemic review and meta-analysis of co-infections in patients with COVID-19 that was just actually is in press. So this paper looked at studies that were published from January 1st all the way till April 17th. Of course, The majority were from China, but there were some papers from the US, Spain, and Thailand, and one from Singapore. So overall, they put together almost 4,000 patients' data. Most of it was observational studies and one RCT. And most of this data is adult. So I'm mainly focusing on adults and will not be talking about children at all. So the median age, as you can see, is 42 to 63, but of course there's extremes. And antibiotic use was reported in 17 studies. And what's important to note is that in 10 of these studies, 90% of patients received empirical antibiotics, which is quite a lot. So in their meta-analysis, they put up a forest plot. I'm sure people have seen this before, but what I want to highlight is that overall, 7% of patients were found to have bacterial co-infections, but there was a difference between non-ICU and ICU. So overall, non-ICU is about 4%, and ICU was 14%. Statistically, these weren't different, but they do, I think they probably in reality are different. It's helpful to know, and this is what you need to take back to your wards as well, is we all worry about these patients and we want to treat them for bacterial infections. But in fact, when you look at these early studies, again, mostly from China, the actual proportion of patients who had bacterial co-infections was quite low, especially for those that were not in the ICU. And that is basically the message I'm going to keep showing you. So in terms of the breakdown, and this paper it's worth looking at this because Mycoplasma pneumonia was their highest, and this was actually diagnosed by the IgM. So it's pretty questionable how reliable this is. So aside from that, the rates are even lower than what they're showing if you go by culture. So Pseudomonas was surprisingly common in this group, and then H. influenzae and Klebsiella, you can see the spectrum here. But what I wanted to really highlight is that the Mycoplasma pneumonia was a lot of it, and that's a bit questionable based on the way the diagnosis was made. And the authors actually say that as well in their paper. So in terms of viral pathogens, there were actually more viral pathogens that were reported. And again, remember, the majority of this was from China, and it was during winter for China. So this may be very seasonal and has not been found in many other places, especially as the year has gone on. So in China, at least, the majority were RSV, influenza, rhinoviruses, all the kind of winter viruses that you would expect. Now, along the heels of that paper, this paper also came out, and it's actually quite a good study. It's from the UK. It's a cohort study looking at 2 acute NHS hospitals, and they looked retrospectively. And what they wanted to do, and which they did, is they looked at 836 patients who had SARS-CoV who were admitted and hospitalized during this time period, February to April. But they also compared it to 216 influenza patients who were also hospitalized during this time period. And I think that's a very fair comparison, because we know with severe influenza and even just regular influenza, we do see co-infections. So, and I think that was our first response, was let's treat these patients the same. Let's give them, antibiotics up front. They may have a bacterial co-infection, but in fact, they found that there were differences. So in this study, they compared the 2 groups, and overall the follow-up median was only 6 days, although the range was longer. So many of the patients did go home fairly quickly. Overall, there were low rates of co-infection in the COVID patients, which I'll show you. And their overall early confirmed bacteria were isolated only in 3.2%. So again, similar numbers to the other paper, 3.2%. The other paper, when you looked at the earlier infections, non-ICU, it was about the same, 4%. So, but I'll show you the breakdown. There was definitely a difference in age between the SARS-CoV-2 patients and the influenza patients. The SARS-CoV were much older. The average median age was 69, and influenza was 36, so quite a big age difference. More men in the SARS-CoV-2, 62%. Compared to influenza. And then, but in terms of how many patients got blood cultures, it was very, actually more patients in the SARS-CoV-2 got blood cultures than influenza. Statistically, though, the numbers don't look that different. And similar patients had respiratory cultures, and then many of them in the SARS-CoV-2 actually had pneumococcal antigen and Legionella urinary antigen sent. So when you look at the blood culture results for SARS-CoV-2, 77% of patients of that 836 all had blood culture sent, which is actually quite impressive and a high percentage. Overall, the yield of blood cultures was 9.3%. But when you broke it down between contaminants and true pathogens, it was only 3.2% that actually had true clinical pathogens that grew from their blood. Many of them were contaminants, the majority of which were coag-negative staph. Interestingly, their sources of bacteremia, they said there were only 2 that were really respiratory. They had some patients who had line infections. So remember, this is overall during their whole entire hospital stay. So some of these were more hospital-acquired infections. There were some that came in with UTIs and some that developed them during the hospitalization. And then these are the other ones. So this is sort of all together, not just those who first came in, but during the whole course of the hospitalization. The blood culture results for influenza patients overall was 6% positive, and there was really no difference between true bacteremias or contaminants between the 2 groups. So for respiratory cultures, as you know, COVID patients often have a very dry cough, and it's very hard to get any sputum from them. So that's reflected here, where only 13% overall did they collect sputum cultures in. So of the 13% that they collected, 35% were positive. But again, it's important to distinguish between those who they got samples when they first came in or later on during hospitalization. So 35% or almost 36%, 1/3 of them were community acquired, but the rest were hospital acquired. And that's important to remember, and it speaks again to what's happening later on in terms of infection control and ASP, which we'll talk about. So not surprisingly, the hospital acquired were more likely to be the Pseudomonas and the more resistant AMP-C, Enterobacteriaceae, things like that, things that were not very susceptible to simple beta-lactams. So breaking down the respiratory cultures some more between the 2 groups, 57%, first of all, from both groups had no growth. So again, very low numbers of patients are getting positive cultures when you can get them. Interestingly, there was more Staph aureus seen in the SARS-CoV-2 group, including community acquired. So the first number is community acquired, and these are hospital acquired. So based on when the cultures were taken and grown, whereas Pseudomonas was seen later on, as well as more of the other ones. So that's actually quite interesting, because we always think of influenza as having the Staph aureus co-infections. In terms of, I'll talk about the Candida and Aspergillus in a little bit, but that was reported here as well. So urinary antigen testing was extremely low yield, probably definitely not worth sending off on our patients. As you can see here, none of them were positive except for 1 influenza patient. So in terms of secondary fungal infections, let's go back to that. 3 patients had Candida albicans bacteremia, which was central line associated. So clearly that's hospital acquired. And a fair number, 20%, had Candida isolated from the respiratory samples. And those of you who think about ASP a lot, when you see Candida in the sputum, we don't think about Candida pneumonia, because that rarely happens. It's just more reflective that these patients have been on antibiotics, and the only thing left that can grow is the Candida. So some of that is probably related to antibiotics given before the patients, made it to the ICU. 3 patients had Aspergillus fumigatus, of which 2 they felt should be treated and were possible infections. But importantly, the serum galactomannan did remain negative for all of these patients in their paper. Just to go back to the first paper, they also did report some fungal pathogen data, and I saved it to bring up here. So Candida albicans was found as well in respiratory tract samples, and then 1 in the urine. Again, these are usually colonizers and reflective of being on broad spectrum antibiotics. Glabrata was also found in 1. And then there were cases, 3 of them, of Aspergillus growing from respiratory tract. And this brings me to the next topic, which is Aspergillosis in patients with severe COVID-19. So it's not something we think about, and actually even in Singapore we haven't seen, but there was a lot of reports during the H1N1 outbreak of invasive pulmonary aspergillosis with severe influenza. Some centers report about 15%, but others say 20 to 30%. And these are patients who come in and go straight to the ICU with severe influenza. And so it's fairly early onset, almost quick, within 3 days of presenting to the ICU, where they grow out this Aspergillus. And of course, it does have a high mortality. So with severe COVID, this is also being described. So previously immunocompetent patients who are coming to the ICU with severe COVID have been described to have pulmonary aspergillosis. And the mortality rate so far, from what you can see of what's been published, is anywhere from 30% to 80%. Now that's, of course, given the background mortality rate, as you know, with severe COVID, which is also quite high, or was high, depending on where you are. One paper that compared COVID with Aspergillus versus without didn't show a difference, but it's very early, so we can't really make any conclusions yet. Interestingly, overall, when you look at the report so far, the serum galactomannan may not be positive. And the diagnosis instead is being made by tracheal aspirate, where the BAL or the trach aspirate culture grows it out, or the Aspergillus PCR is positive, or the trach aspirate or BAL galactomannan is positive. Importantly, you need a high index of suspicion. But of course, we know there's always this issue of, is it there or is it actually causing invasive disease? So I'll show you some case reports. So this was a 73-year-old man. This was a patient from France. And this was a 73-year-old male patient who was asymptomatic for myelodysplastic syndrome. So they really went out of their way to say he didn't have active MDS, wasn't on any treatment. His only diagnosis for MDS was based on eosinophilia. They call him immunocompetent, actually, not on treatment for that. And he was admitted with respiratory failure. So he was admitted on his 7th day of fever and cough. So exactly when you would almost expect someone to crash with COVID. And he was diagnosed with COVID. His initial trach aspirate. So a lot of these, I should stop and say, a lot of these countries, Netherlands, France, even the UK, will do sort of weekly testing for aspergillosis in their severe influenza patients. And some of them have taken the same practice to COVID. So in this patient, they sent off the Aspergillus PCR on day 4, and it was very low copies. And so they also did a galactomannan and it was negative, so they didn't treat him. They repeated it on day 9, another trach aspirate, and at this point the PCR came back much higher, 3,600 copies per ml, but the serum galactomannan remained negative, and they didn't have a result for the trach aspirate galactomannan. The patient died the same day, but what happened is subsequently the tracheal aspirate culture from that day 9 grew Aspergillus, and you can see the nice hyphae with the 45-degree angle and the septates here. So that's very classic for Aspergillus, and that's what grew. There you go. So another paper published in Mycoses described 5 separate patients, and these are their CT findings. And I show this because most of the reports basically show that you really can't tell from either the chest X-ray or even the chest CT that this is Aspergillus. So it's usually just sort of bilateral infiltrates, which what you see with COVID, like here. And then in these, they do describe these small nodules. But I think that unless, again, you really suspect it and you check all the other, you send off the trach aspirate or the BAL looking for it, you won't suspect it necessarily just on the scans. So this paper just also is in press now, and it's from Switzerland, Lausanne, and they looked at it's from 2 different hospitals. And in their case, they do weekly serum galactomannans, as I had mentioned, as a routine in their ICU. So they had 80 patients who were admitted serially to the ICU from March 6th to May 11th, and they had found with their weekly galactomannan routine that they had found 3.8% who probably had either putative or probable IPA. So they did, surprisingly, they said this was a low rate, 28% of patients had BALs, but actually that's quite high. As you all know, most of the time we're avoiding doing anything that's going to cause more aerosol generation to protect our healthcare workers. So 28% had BALs, and that's why only those who had BALs could be called probable. Otherwise, if it grew from the trach aspirate, it would be putative. So importantly, all patients had received TOSI within 4 days, but just to be clear, when you read through the paper, most of their patients had gotten TOSI. So it didn't look like that was the risk factor. In terms of who those patients were, All of them, 2 of them actually had some underlying pulmonary lung disease. And in terms of timing, most of them were relatively early, at very soon after being admitted to the ICU. This one was 3 days into ICU admission, this was 8 days, and this was 7 days into ICU admission. And the patient who had the probable is the one patient who actually died. So this was probable because they had done the BAL culture, like I said, and also the patient had a positive serum galactomannan, and the serum beta-D-glucan was positive as well. So this is, as you all know, with Aspergillus, it's always a question of how do you define the diagnosis. And right now there are debates going on about whether to use the same sort of categories as they did with influenza. So in this paper, 2 out of 3 actually survived. So with the amount of antibiotics that are given, I think it's worth talking about, is there a need for antibiotic stewardship in COVID? This is the NUH ASP team. This was last year's World Antibiotic Awareness Week, which WHO sponsors. I think this year we won't be able to have any public events like this. But that brings me to discuss how frequent antibiotics are being given in these patients. So some of the papers I already showed you, those 10 studies where 90% of patients were given antibiotics. And now you've seen that the co-infection rate, especially early, is quite low in the 3 to 4% range. So this paper came out in CID right around the time that we were presenting this to our group on our ASP algorithm for COVID. So in this paper, they also looked back at some studies and found that the rate of co-infections between bacterial and fungal was 8%. But they didn't really distinguish between, in this paper, they didn't look and see what was significant or what was clinically significant and which was colonization. And they made the point that most studies failed to tell you when the sampling was taken. But what was important and highlighted was that 72% of patients received antibacterial therapies. That's quite high. And interestingly, atypical pathogens were low, which they raise as an issue, especially when people are giving macrolides or quinolones and the issues with QTC prolongation. Most of the co-infections, though, were healthcare associated, and again, emphasizing the importance of infection control, ASP, and surveillance. They did raise the question of using Procal to help distinguish who really needs antibiotics. And they ended it with saying the importance of ID specialists and microbiology labs to provide support to clinical teams in managing antimicrobial therapy in COVID-19 is very important. Or I added on, or having an ASP team. So this isn't probably the time to start an ASP program, but it really does call for oversight of antibiotics and helping the teams take care of these patients, at least making them feel comfortable. So when we at NUH, our ASP team wanted to review this and kind of come up with an algorithm for our own hospital, we looked at some of the existing guidelines. And the Surviving Sepsis campaign did come out with some guidelines, and so of course these are the very sick patients who go to the ICU. So they did say use empiric antimicrobials over no antimicrobials, treat according to clinical syndrome, as are the WHO guidelines you just heard about say, which is it CAP or hospital-acquired pneumonia, decide on your treatment based on that. But also assess for de-escalation daily, evaluate duration and spectrum, and be judicious as again, given to you by early as right at the start of this talk. So the NICE guidelines, which were also rapidly published on May 1st, said stop antibiotics if the pneumonia is due to COVID and there's no evidence of bacterial infection, which is also worth noting. And then this came out as well soon after that, and this was a rapid advice guideline for diagnosis and treatment of COVID. And in here, they do say avoid blind or inappropriate use of antimicrobial drugs, especially a broad spectrum antibiotics. This is interesting because it actually came from China and they had used so many, but they also, when they published their data, showed that over and over stated that patients who had antibiotics and those who didn't, there was no difference in mortality. So in other words, we shouldn't be just blindly throwing antibiotics, even though these patients can come in quite sick. So as I said, this was evidence-based, and this was published from Wuhan University in China, and they followed the WHO guidelines and the WHO rapid advice guidelines. So closer to home, NCID is our National Center of ID. They did put together interim guidelines for COVID, and IDSA did as well, but they did not include any information on antimicrobial use. So what we did is look through the literature as well, and as some of it I showed you, and some of it is now summarized in the meta-analysis to show that the rates of co-infection are quite low, especially when you don't have severe disease. And based on that, and based on looking at procals and CRP cutoffs as well as white counts, we came up with an algorithm. So I'll show you a closer view of the first half. So basically, initially when patients were admitted, and I'm sure this is a learning curve that happened everywhere, including China, many of our patients did get started on community-acquired pneumonia. And often the antibiotics were stopped once the COVID came back positive, but not always. So the first principle is that if the chest X-ray is negative, meaning it falls under the mild category that Dr. Kobayashi just showed you, then you shouldn't even consider antibiotics and just withhold and continue monitoring unless there's some other source of bacterial infection that the patient happens to have as well, then of course treat that. If the chest X-ray shows infiltrates, then you need to decide, is this severe disease as defined, shown earlier, which means the patient requires oxygen, or they're having rapid progression of their infiltrates. So, within a few days, 50% infiltrates go up by 50%, that would be considered severe, or they're in the ICU, then certainly use, we direct everyone to our NUH pneumonia guidelines, but you can give your local guidelines. If they don't have severe disease, then you could do some more investigations, look at the white count, look at the CRP, and then consider looking at the procal. So again, the white count typically for COVID is low, so we had a cutoff of over 10 to say if it's over 10, then definitely consider antibiotics. CRP, as you know, is a reflection of IL-6, and it does go up with severe COVID, and it's sort of a predictor of developing severe COVID and even going on to higher mortality. So, but it still tells you that someone is heading towards severe disease. So we thought it was fair to say CRP greater than 60, which has been the cutoff from the China data. And at that point, you should look at procal. And if the procal is less than 0.5, then you can sit tight actually and withhold antibiotics. If it's greater than 0.5, then you could consider starting antibiotics. So again, this is for the non-severe. So the group that's moderate that was described earlier, meaning they do have infiltrates, but they don't fit into the severe category. They're not requiring oxygen, and they don't have rapidly progressive infiltrates. So this gives you a little bit of a more practical approach, and you can look at your own patients. So we did this because we wanted to be consistent with our ASP guidelines. So we just referred them to our NUH pneumonia guidelines in terms of what to start. So again, if it's very community-based, non-severe, our guidelines just say to give azithromycin. Alternatively, I would like to write in here amoxicillin as a start. But for community patients who are severe, this is our severe guidelines. This is what we use anyway for CAP, but these patients should be in the ICU. And then of course, if they're hospital acquired, so they're progressing and they've been there for more than 48 hours, then these are our guidelines. So what we wanted to do is look and see, did this algorithm, how did it look when we actually looked at a cross-sectional review of our patients in the wards? And so the way our wards were, especially when we had a lot of COVID patients, as you all probably know, Singapore has actually done a very good job so far in keeping these patients, keeping the numbers down and actually having very mild disease, luckily as well. But during this time, all patients were being admitted, and we had community cases, we had imported cases, so it wasn't just in the foreign workers, which is where our epidemic is now. So we had we had 3 full wards, and ID was really only managing one of those and then overseeing the other one. So we didn't have full control of the antibiotics. So we looked at a one-day cross-sectional review on May 6th, and we wanted to see what was the percentage of antibiotics being prescribed on these patients, and then how would it have worked out with our algorithm in terms of fitting, would they have required antibiotics or not? So in terms of inclusion and exclusion, real quick, inclusion was just antibiotic. These patients were admitted to a COVID ward and they met the at that time MOH definition of confirmed or highly suspect. So we didn't want to include the low suspect cases. Many of the patients were being admitted just to rule them out, just to keep our hospitals safe from an infection control standpoint, but they were considered low risk. So we excluded those patients. We only wanted to include these ones that we really suspected COVID in. And we looked at whoever was admitted on that day in those wards, we looked at their antibiotics over the 14 days before and after. And we only looked at antibiotics for patients who were started on it again for pneumonia or respiratory infection. So if they had some other reason that antibiotics were started, which was indicated in the notes, then we didn't include them. So overall, after you screen for all that, there were 23 patients who had 47 courses of antibiotics, but 5 of them were given antibiotics for other reasons. So it turned out we had 18 patients who had 33 courses of antibiotics for that one day. And so that was 15% of confirmed and high suspect COVID patients were given antibiotics overall. And the total number of courses was actually even higher at 33, because sometimes patients got more than one. So when you looked at who was in the general wards versus ICU and how many courses, here you can see the general wards were 16 patients who got 26 courses, and ICU was 2 patients, but they got 7 courses, including 1 patient who had 5 courses. So you can see we have a little bit of an antibiotic problem, I would say. So in terms of signs and symptoms on the day that antibiotics were started, of course, 83% of patients had fevers. Chest x-ray findings were found in 60%, 61%, and both fever and chest x-ray findings were in 50%. CRP wasn't very high, over 60 and only 22%, and the total white count was high in only 1 of those patients. And only 1 patient had a procal. So here people weren't using a lot of procal. Now, CAP and fever were the most common indications to start antibiotics, as you can see here. And so these are what's written in the charts. Now, not surprisingly, the main antibiotics that were used were the ones in our algorithm, in our guidelines for community-acquired pneumonia. So that was pretty consistent. And the other good thing here is that when you look at duration, so 1 to 2 days is blue. So 55% of patients' antibiotics were stopped, mainly when the COVID PCR came back positive, then ID stepped in and said, okay, you can stop the antibiotics. But still, the other 45% did get a longer course. So when you looked at their inflammatory markers, and especially comparing day 1 and then day 2 onwards, between ward and ICU, the white counts for any of them weren't very high, although ICU was definitely higher. CRP, the median CRP on day 1 was 52, but for ICU was much higher, as you would expect. And the procal, like I said, wasn't really done, other than, not actually done in the general ward at all. So what about cultures? So out of the 18 patients, 9 of them had blood cultures taken, and 3 of them had sputum and blood cultures. 6 did not have any cultures, and all of the cultures were negative in these patients, except for 1 ICU patient who had 2 ETT cultures that grew Candida parapsilosis, probably again reflective of already being on antibiotics. So how did our proposed algorithm do? Well, when you look at it, 4 cases met our ASP algorithm. So 4 cases had severe disease. There was 1 who had non-severe disease whose white count was greater than 10. And then there was those with chest x-ray changes and non-severe disease who had, there was 1 who fit in with the chest x-ray changes and non-severe disease. And then there were 2 patients who had gone to the ICU. So we felt that based on our algorithm and based on how these patients did, that we overtreated 14 patients with antibiotics. But we haven't really validated this algorithm. So all we can say is that based on this, we did overtreat patients. So one other thing, and so actually we're now in the process of looking at a much bigger cohort of our patients and looking at our algorithm that way. But one of the things we also did is look at more closely at our ICU patients over a longer period of time. And so 23 COVID patients were admitted to the ICU during this March to mid-June time, and 21 of them survived and 2 were non-survivors. Overall, 65% of patients were treated with antibiotics before coming to the ICU. So one of the reasons we did this is we want to talk to the ICU doctors and really also to the general doctors, and really try to get people to not start antibiotics too early, because when you start looking at the long courses in the ICU, you want to keep those patients from having been exposed to too many antibiotics. So unfortunately, 8 patients were given antibiotics even before being admitted to the hospital. And you can see those were the antibiotics given. And then, of course, patients were given it in the wards, as we've already discussed. One patient even got Pip/Tazo prior to getting to the ICU. So this is days of treatment in the general ward prior to ICU admission. So Azithro is given for 3 days, so that this patient would have gotten Azithro plus probably Augmentin. So this adds up. It's just for each antibiotic day, you get 1 point. But you can see that the antibiotics really do add up pretty quickly. So on day 1 of ICU admission, 21 patients were changed or started on antibiotics. And of course, I don't know about your hospital, I'm sure it's similar. At ours, if patients are sick and they come to the ICU, they often get meropenem to start with because of our community-acquired ESBL rates, which I don't think are as high as some of the other countries in South Asia, but they're still there. We still have community-acquired ESBL. So 9 were started on Mero, 3 were started on Tazocin, and 5 patients got our triple combination for severe community-acquired pneumonia. And 4 patients were started on Augmentin, which is nice. So these were probably patients who never had antibiotics. The median ICU stay was 8 days. And if you look overall, there were prescriptions while the patients in the ICU, these are the overall prescriptions for all 23 patients. So every time a doctor ordered an antibiotic, that would be considered a prescription. So you can see quite high, especially for Pip/Tazo, Mero. There were 8 for vancomycin. And this really matters because of all the antibiotic resistance. So we do need to be very mindful of how much we're using. And especially because for the last 6 months, I think all of us are sort of focused on COVID. So, and that's what patients are coming to the hospital for. So over the long run, this will have a big impact on antibiotic resistance. So in terms of the initial ETT cultures, and these were cultures that were sent on day 1, not everyone had cultures sent. So 16% didn't have any culture sent from the ETT tube, even though they were intubated. But if you look of what grew, only 17% would really require treatment. So here, 17% grew Klebsiella, another 70% grew normal flora. Then there was the Candida albicans, probably because they were on antibiotics, and 25% was no growth. So that's the type of data we plan to take back to the ICU as well, just to help them be a little more mindful of their antibiotics. Overall, though, in terms of over the course of the ICU stay, there were obviously many more positive cultures. So 8 patients, I think these are I already showed you in the first one, but later on patients grew Candida, they grew Stenotrophomonas. 2 patients had the Klebsiella grew, 1 patient had M. abscessus that had actually grown before and was treated. And then in terms of blood cultures later on, there were line infections with Candida, 1 patient grew Pseudomonas, and there was this odd Ralstonia species, also coag-negative staph and the usual contaminants. So this again is important because these all speak to more hospital-acquired infections, infection control, issues that also need to be addressed. So NUH has a problem with, as do many other hospitals, on resistance. This is the NUH dashboard that looks at our year to year at our data on some of these things. And so you can see our MRSA bacteremias have increased, our CPE, our CRE, which is basically CRE rates, our clinical isolates have increased, and so have our screening isolates. And then our C. diff rates have gone up as well. So these are all, if you look at one underlying cause to put this under, so one umbrella reason, it would be, of course, overuse of antibiotics, and especially the carbapenems and the broad spectrum antibiotics. So I say this because, again, we're all taking care of a lot of COVID patients. Everyone's focused on this. They are sick, but we should think about the fallout with our antibiotic resistance that will happen if we overtreat. So our summary from our one-day review was that we did okay overall, but we could do better. So generally speaking, our antibiotic courses were short, but we did start 15% of patients in COVID, of our mild to moderate patients on antibiotics. And as we showed before, the co-infection rate is really low, maybe 3%, 4% at the most. So we probably didn't need to give all those patients antibiotics. So what we feel is if you can reduce your antibiotic usage early, then by the time those patients who become sick get to the ICU, you can actually be able to use your smaller gun antibiotics, or at the time that they really need it. If you start, most of these patients, as you know, are well and they don't have severe disease. So at that point, we shouldn't be giving any antibiotics if we can help it, or looking at the risk factors. So for instance, again, looking at the Y count, the CRP, and the procal, and then deciding who really needs it. And then for those who do get sick, you have smaller, you can start with even Augmentin if they're going straight to the ICU within the first 2 days, and not have to start with meropenem. So in summary, the rate of bacterial co-infections in non-ICU patients is low. Again, really probably 3 or 4%. Bacteremia rates are also very low. So these patients generally, compared to influenza, have fewer co-infections with bacterial infections. These, again, are those mild to moderate cases. Of course, severe, we do think you should give antibiotics, but get your cultures first so you can de-escalate. So when we say 4%, that means 96% of patients with COVID admitted to the ward do not have a bacterial co-infection. So it's important to phrase it that way as well, because it sounds much more convincing. So mild to moderate patients will have fevers, they'll have a dry cough, bilateral infiltrates, and you do worry about could there be an atypical pneumonia there? But there's now a lot of evidence looking at cultures that most of the time there isn't. And so I would say you should look at, procal, Y count, clinically, how's the patient doing? And judge then, especially for the moderates, whether you need to start antibiotics. Now, by the time they progress and need oxygen, or they're developing severe disease, then yes, it's okay to start them on antibiotics empirically, but then de-escalate or give a shorter duration. So I think we really do need ASP, or at least ID presence, as we talked about. It is ideal to get to the ICU with little or no antibiotic exposure, so that way patients will have a better chance in the ICU and will be less likely to have all that resistance. We can use lab values, as I said. If we don't give antibiotics ahead of time, we can get reliable cultures, both from the blood and the trach aspirate, and then we can de-escalate based on those. And just remember, many of these patients do have a very prolonged ICU stay. You've seen reports now of bacteremias and candidemias and things like that. So with that, I would like to thank our ASP team again, and we can talk about whatever questions I have generated. Thank you.
Thank you, Dr. Somani. That's a very interesting discussion, and I can tell because the questions are starting to come in. And by experience, we usually, a question generates more questions, and that's very good. So perhaps let me start the ball rolling by asking this first question, which I think your summary did respond. So an anonymous attendee is asking, for those who are COVID-confirmed asymptomatic patients with pneumonia on chest X-ray, should antibiotics be given? So I think it was, but if you could reiterate, please.
Sure. Thank you for the question. And no, I think that's a good question to just make clear. We don't need to treat those patients. We can just watch them.
Right. It's a very crisp but a definitive answer, because we have a lot of frontliners who are actually quoting our lectures and saying, hey, you know what the expert or WHO said. So, okay, another question. So how does a chest X-ray of a COVID-19 pneumonia patient differ from that of a non-COVID-19 patient? Is there a distinctive pattern in the X-ray that would suggest COVID-19?
So that's a very good question as well. There's nothing perfectly distinctive, but actually what you do see is a little more of peripheral infiltrates on your chest X-ray. And that is pretty characteristic, I can say, of COVID. So you see either bilateral, which is more common than unilateral infiltrate. So you can see unilateral, but bilateral is more common. And often it's very peripheral. Later on, of course, as they progress, it can fill in, but it's not pathognomonic, but it is pretty characteristic. So peripheral bilateral infiltrates and usually lower lobe. But of course, nothing is 100%, but that is the classic lower lobe peripheral bilateral. Chest CT also has some classic findings. It's that crazy paving that they describe, and your radiologist would know it. So radiologists get pretty good at this, especially if you have a lot of COVID patients, so you can always ask them as well. I mean, it's really hard. And one of the things about not giving antibiotics, even when you have a patient with infiltrates, who's either asymptomatic or even febrile but not requiring oxygen, is really talking to the families, talking to the patients, and really explaining that you are going to cause more harm. Even though it seems counterintuitive, people always think, oh, well, let's just give antibiotics. I would feel better, they would feel better, and what is the harm? And so the harm is what's hard to measure, but there really is a lot of harm that comes out of it. So we know we get higher rates of C. diff, higher rates of resistance, all those things, and not just for your hospital, but even for that individual patient. So the communication has to be there. You do need to explain why you're withholding it. It's not that you're withholding it because it's better for the hospital. It's actually better for the patient. But remember, you're in an acute care hospital, you're watching these patients closely. So you do need to reassure them that if things change, you will start antibiotics. And most of the time you'll get away without having to.
That's a clinical pearl right there. If I was a GP or even an internist, who is not an IDS specialist, I would remember that it's not just about withholding, but it's about explaining why. And I just wanted to take this chance to emphasize the message that I picked up from Dr. Somani when she said that if antibiotic use is decreased early, by the time the patients reach the ICU, then you can use these so-called smaller guns instead of going for the bigger guns, which would probably be more expensive, and they're going to start running out of supplies and so on. So that's a very good point to make. Like, withhold it now, but if it's really needed, then we give it. Okay, brings me now to another series of questions. I'll ask two questions, Dr. Somani. So this comes from colleagues in the Philippines. So Mark Pasayan and Gerarda Afable are asking similar ones. So the first question is, should latent or active tuberculosis co-infection, especially in high prevalence areas, the Philippines is one of high prevalence areas, should tuberculosis be a concern when starting tocilizumab? So it's not entirely an antimicrobial, but valid question. When starting toci in patients with COVID-19, that's the first question. The second question, I do understand that you mentioned you did not touch on pediatric patients, but just in case you might be able to answer or there's some information out there, please comment on COVID pediatric patients with tuberculosis or who had a previous history on TB with a prior lung injury. What's the experience when it comes to diagnosis, management, and outcome? Over to you, Dr. Somani.
Sure, thank you. So for the first one, we have seen patients who've had TB here, and it is definitely something to consider and rule out before you give toci. I think luckily we have the dexamethasone trial now, so we are less likely to give toci now than we would be, to give just the dexamethasone, because it is a consideration. So definitely, and we also have a fair bit of TB in Singapore. We're an intermediate burden country, so we do see it. And we have had patients we have a lot of, as you know, foreign dorm workers right now who are coming in with the COVID, and most of those are from India, Bangladesh, and other places where endemic rates are high. So yeah, definitely think about that before you give toci. And in terms of the peds, I can tell you here, generally the kids have done very well with COVID. We haven't had any long-term issues or even very short-term issues. So I can't really answer the TB part, but certainly any patient, including a child who's had TB, is going to have ongoing scarring and changes in the lung. So it's important to look at the previous chest x-rays. Any clinician needs to do that so you can determine whether they really have pneumonia due to COVID or if the changes were old changes.
Great. So the time is 11:54. By experience, we do overshoot a bit. I hope you don't mind, Dr. Somani. Perfect. So because the next three questions deal with the ASP algorithm that you showed. So Jose Ilao, an anonymous attendee, and Ruema Perez are asking the following. First question, Can you please give us the sensitivity and specificity of the procalcitonin portion in that algorithm? Why wait for a high CRP before doing a procal test? That's one question. The second one, which is related, what is the recommended monitoring interval for chest X-ray, white count, CRP, and the procalcitonin? And the final related question is, if it is all right, please let us know the role of procalcitonin. Why are we checking on procalcitonin? Over to you.
Okay, great. So great questions. And I don't know if I have all the answers. So in general, procal pre-COVID, the data for procal actually was for community-acquired pneumonia in terms of whether you need to start antibiotics or not. And so the thing about procal is the negative predictive value is very, very good. The positive predictive value isn't so great. So it's a very specific test, and the negative predictive value is what's helpful. And that's true for just community-acquired pneumonia. So if patients come in, because as you know, many community-acquired pneumonias are also just viral and don't require antibiotics. So that's where the procal first came in, and a negative procal is what you really can act upon. So it's very reassuring. And so the same thing has been shown with COVID is if the procal is negative or low, then you can be reassured that the CRP is rising because of the COVID and not because of a co-infection. Positive procals are much more difficult to interpret because you do see false positives. So I can't say too much about it other than if they're really high, they are predictive of bacteremia. So I don't have exact sensitivities and specificities for COVID, but taking from what we know with community-acquired pneumonia, most of us are applying it there. You don't have to do a procal. As we said, most patients with COVID, we saw the numbers in the beginning, will have mild disease and you don't need to do a lot of testing. But these are for those who continue to have fevers and do have bilateral infiltrates, and you just want to reassure that you're not missing something. It is helpful to look at. No one test is ever going to tell you for sure if someone needs antibiotics. That's why we do a mix of things. We look at chest x-rays, progression, we look at white count, and is it going up or down? And we look at procal and CRP. So depending on your setting, you should not do one, but you may not be able to do all of them either. So you have to be a little bit realistic with your setting, but that's why you can't rely on one test. And so in terms of how often do you do it, some of it depends on how's the patient doing. So if you're listening to their lungs and now they have new crackles, new lung findings, then you should do a chest x-ray. If they're continue to have fever and their CRP is going up, you should definitely do a chest x-ray, because with COVID, sometimes you may not hear something and there may be some early changes on chest x-ray, although usually it's the opposite in COVID. You hear things and the x-ray shows up later, and that's why in China they did CT scans. So the lung exam is actually quite helpful with COVID in terms of hearing things. So how often you do it is again dependent on how the patient is doing. So I would definitely repeat it. So we do SATs on a 3 times a day basis for our inpatients, where we're checking O2 sats. If the O2 sat is dropping at all, then we do a chest x-ray for sure. We also do an ambulatory SAT. If there's at all, it's borderline, because sometimes the patients don't have the symptoms of shortness of breath, but the SATs start to fall. So that's another very simple test to do that should be monitored for your COVID patients. In the interest of time, I'll probably stop that answer there.
No, that's perfect. I mean, that's like a lot of clinical pearls coming our way. So the next question is probably for those who are seeing a lot of the mild to asymptomatic patients in ward. So a participant is asking, for confirmed COVID patients admitted to the ward, around which hospital day is a bacterial co-infection expected, perhaps based on experience or data? That way, we can monitor patients more closely. Has there been data already, or it's still over to you?
No, I don't think there's data, and I wouldn't expect a bacterial co-infection, to be quite honest. I would only expect it in those patients who end up in the ICU. That's really where we're seeing it. Or someone who is older and you put in a bladder catheter or something like that. But prevention is really important. That's why we don't give IVs We don't put IVs in if we don't need to, or we may put them in initially to hydrate the patient and then take it out. We don't put in catheters because most of those bacterial infections are going to be hospital acquired. So I wouldn't expect them. Now, of course, once you get in the ICU setting, these patients end up sometimes on dialysis. They're on the, they're intubated. They have multiple lines in. Then of course, that's when you can start expecting it. So I wouldn't routinely expect, and again, as anything, a patient with COVID is continuing to have these sort of fevers, and then they settle down, and then they get this new fever. That's when we start thinking about a new infection or a co-infection. But I think we can prevent a lot of it by just good, infection control and taking lines out and that kind of thing.
That's a very good soundbite right there. So IPC does, I mean, thanks for that, Dr. Somani. IPC does play a role in this. It's not just about giving the antibiotics.
We also encourage our patients to walk around. Okay, so older people who stay in bed are definitely at risk of getting pneumonia. So we do encourage our patients to walk around, and you should do the same. And that's one of the problems with this whole isolation. But if you can put them in a cohort COVID ward, which is what we did, we converted our wards to being COVID positive, then patients could really walk around within their cubicles and stuff. And so that, I think, is also important. Otherwise, if they're stuck in an isolation room, then they can't really move.
Great. All right. So another attendee is asking, in their institution, the practice is that sputum, gram stain, and culture is obtained only after acquiring a negative COVID result. Is this the way to go, or would there be justification to get sputum even before the test result for COVID comes in? That's the first one. I'll link it to the second one. Stefan Claveria is asking, as most Filipino patients might have a difficulty paying for the big gun antibiotics, may we ask which broad spectrum antibiotics are usually the best to start with prior to culture results?
So in terms of getting sputum, like I said, most of our COVID patients have a dry cough and no sputum whatsoever. So the issue is, would you induce sputum? And we don't. We generally don't induce sputum until we've ruled out COVID. Otherwise, we don't want our respiratory therapist to have to go in and induce sputum, and it's not worth the risk. So I wouldn't even, if they're not coughing up sputum, I wouldn't send a sputum, because like I showed you, the risk of co-infection is actually quite low, especially when they're first coming in. Now, if someone's intubated, then we do send off the ETT aspirate, but many times it's dry. So some of those 17% where nothing was sent, it would have been dry. And that really is a reality of COVID. So, which is good. It just means, again, that there's not a bacterial infection. So I wouldn't send it if there's no sputum to be sent. I would not induce it. And now if they don't have COVID, that's different. But, don't forget, by the time you get pneumonia with COVID, your nasal pharyngeal swab may be negative. The sensitivity of that goes down. So then when we really suspect COVID, we will, if they're not going to be intubated, then we might consider a chest CT, which might show it be more classic of COVID as opposed to a negative chest x-ray. Or if they're intubated, then we always send an ET trach aspirate to make the diagnosis of COVID. So that's another point to make. But in terms of what antibiotic would I start? So again, if they come to the floor and they have mild disease, I really wouldn't start anything unless there was enough evidence to say that there's a bacterial co-infection going on. If they're in the ICU, then, and they have not gotten any antibiotics, but I don't know your antibiogram in Philippines. So it's really important to know your local data. For Singapore, for a severe, but see, patients who go to the ICU with COVID don't have quote unquote severe community-acquired pneumonia. So that treatment is from melioid to Staph aureus to Pseudomonas, that kind of thing. So for severe COVID, if they've not had any antibiotics, I think you can give IV Augmentin or IV ceftriaxone and be okay, because you're really just trying to cover the normal bacterial pathogens that are in our sinuses. And if they've been in the hospital a long time and then they go to the ICU, then of course you need to cover your more gram negatives like Pseudomonas and Klebsiella and things like that. So then you have to look at your own antibiogram and decide which antibiotic can you rely on. Is it piptase, or do you have to go straight to marrow?
Thanks. So I think the key message there for everyone who's listening, check with your local guidelines. There will be data on the profiles available and which particular broad spectrum antibiotics are recommended. Right. So the time is 12:04, and in the interest of lunch here in the Philippines, probably Singapore, same. But okay, so maybe we'll wrap up with just one question, and this might also be related to the topic. So lately, the trend has been there's an upsurge in vaccination for flu. So vaccination for flu, and people seem to be like having concepts like, oh, is it going to protect me against COVID-19? Yes and no, or what's the answer, and how do we explain it to our patients? Because I, as a general practitioner, and I'm sure the others listening in here, like, well, it's on its own, it's good, but how do I explain that? Dr. Somani.
Yeah, well, I think that the main reason to get the flu shot right now, and this is what's being said everywhere, is we don't have room to have severe influenza in our hospitals when we have ongoing severe COVID patients. So it won't protect you from COVID, but the idea is that already our healthcare systems are at risk of being overwhelmed. So influenza, we all know, is not a perfect vaccine. Okay, we know that, but it does help decrease the severity. So it may not prevent you from getting the flu, but you are less likely to get super sick from it. So the idea is you don't want to have to get admitted for influenza in the middle of already having patients who are coming in with severe COVID. And we don't have a vaccine for COVID, so let's at least try to prevent severe influenza. So that's how I would explain it to the patient.
Thank you so much, Dr. Somani. So just like a hospital, it's been tough to triage the many questions. There are quite a number of really good questions still, but
Yeah, I see some of them.
Yeah, in passing through them, I realized that Dr. Somani's lecture, which I understand, Dr. Somani, you'll be providing us a copy of the slides, so she will, and we'll send that out at the end of the day. It's an information-packed PowerPoint, actually. There's a lot of information there, which I think some of the questions can be answered by the PowerPoint. We'll do that. Before we formally close the session, Doctors Gary and Sophie, do you have any last words of advice, or just like me, I've been learning a lot from Dr. Somani. Dr. Gary.
No, I want to thank Dr. Somani for giving such a great lecture. And yes, I learned a lot. The one thing I wanted to mention to the audience is WHO does have a use of chest imaging in COVID-19 rapid guide. It doesn't really, it won't show you specifically X-ray findings per se, but it'll tell you when to get a chest X-ray. Specifically in patients that are asymptomatic, the only times you would get a chest X-ray in an asymptomatic patient is if you didn't have an RT-PCR test or was delayed. That's about the only time, and it'll give other guidance on when and how chest X-ray, CT might be useful in COVID-19. Thank you.
Dr. Sophie?
Sophie, I think you're on mute.
We can't hear you at the moment. Oh no, microphone issues. We can see you. Can you try again? Okay, sorry for that. Sorry for that. So some technical difficulties. Thanks again, Dr. Somani. Just to echo what Drs. Kuniyoshi and Dennis and myself, on behalf of the WHO, thank you so much for guesting here in our webinar series. We hope to hear from you again soon. Definitely, this is a protracted emergency already. I mean, that's not an official declaration, but I'm just like saying that's the sense right now. And we do value insights, especially those valuable clinical pearls that just like pop out of the lecture, which I'm sure all 440 plus 94. So roughly still above the 500 mark participants, not only from the Philippines, but also from Singapore, quite a lot of registrants, and from all over the Pacific and the Western Pacific region. Thank you so much, everyone.
Thank you for inviting me.
Thank you. And we wish everyone a good day. Wherever you are, please stay safe. Bye.